My name is Solomatina Nadezhda Nikolaevna. I am your lecturer. Today I'd like to tell you about traumatology of the maxillofacial area, face injuries, lower jaw fall. Causes of the maxillofacial area injuries can be traffic accidents, falls, bruises, sports-related injuries, work injuries, and gunshot wounds. They result from stabs and wounds, animal bites, firearm wounds, or etc. In peacetime, home accidents dominate and account for up to 75% of all injuries. In wartime, 5% of all injuries. Medical care is provided by surgeons, traumatologists, and dental surgeons. Soft facial tissues wounds can be incised, tear contused wound, and puncture. You can see the same injuries in these pictures. Oh, sorry, not injuries, trauma. They are characterized by the following features: edema, opening of wounds edges, lip and chin skin maceration, which is caused by constant hypersalivation because of tissue defects, neurological symptoms caused by damage to the peripheral branches of trigeminus and facial nerve, salivary fistulas in case of damage to the parotid salivary gland. Soft tissue wounds may be isolated or may be accompanied by facial bone fractures. In this, you can see facial soft tissue wounds. And in this picture you can see facial soft tissue wounds too. Let's tell you about face bone fractures. Fractures of the jaws and facial bones are more common in adulthood, 20s or 40 years of age, and in men. In children and adolescents, almost 25% of all fractures of the jaws and facial bones occur. Fractures can be compound, open, and subcutaneous, closed. Open fractures prevail because of the damage to buccal mucous membrane, which is tightly made to the periosteum. Maxillofacial area wounds. The close proximity of the brain, main blood vessels, trachea, and esophagus is often the cause that aggravates the general condition of the victim. Damages to the bones of the facial skeleton are combined with a contusion or brain contusion. Different damages, the presence of a foreign body or compression diatotrachea edema dramatically aggravate the patient's condition and sometimes can cause their death. Without emergency care, wounds of large vessels, external carotid and lingual arteries can cause a quick death of a person. The wounds of soft tissues and jaws contribute difficulties in mastication. Infection contributes to the rapid development of the inflammatory and purifactive process. In case of facial soft tissue, edema, constriction, and displacement of muscular cutaneous flaps, the wound may seem severe. Early complications. Blending. A significant number of blood vessels in the maxillofacial area can cause excessive blending. Skin blending, it can be stopped with a pressure bandage. It's difficult to stop the blending when the vessels of the mouth cavity floor and the soft palate are damaged, because tamponade can lead to respiratory stress, gagging. Sometimes it's necessary to press the external carotid artery to the processus transversus of the sixth cervical vertebra to reduce bleeding. In case of humoral sinus or nasal cavity bleeding, a tight tamponade is used. Bone bleeding can be stopped if it's possible to put together the wound edges and to fix jaw fragments. The second, asphyxia, dislocational, stenotic, obturative, valve, or aspirating form. Dislocational asphyxia is characterized by tongue impaction. It's necessary to fix it. Obturative asphyxia takes place when the lumen of the respiratory tube is closed with an extraneous body. It's necessary to remove it with tweezers or to conduct tracheostomy. Stenotic asphyxia is a compression by hematoma, subcutaneous emphysema, and edema. In such a case, tracheostomy is desirable. Valve asphyxia is caused by the closure of the soft tissues of the plate or pharyngeal wall with a flap. Flap fixation is required. Aspirating asphyxia means aspiration of blood, saliva, and vomitus when the victim is unconscious. If injured, person should be in face down position. Emergency care is required. It's necessary to restore the patient's breath, to know how to administer artificial respiration mouth to mouth in case of clinical death, to the entire arsenal of resuscitation techniques should be used. And the next, traumatic shock. Traumatic shock in case of the nerve trunk damage, neurogenic shock is observed. It's necessary to stop the bleeding, to anesthesize the patient, to stimulate the cardiovascular system activity, and to block emotional stress components. It's important to ensure the jaw fragment immobilization and to impose an aseptic bandage. Patients are treated with sedatives, which relieve tension and fear. Anti-inflammatory, antipyretic, antihistamine, desensitizing drugs are also used. Anti-shock complex includes trihazine, androxine, promedol, analgin, diphenhydramine. Medication should be taken every 6 or 8 hours. Examination early of patients with facial injuries. It's necessary to clarify the circumstance and mechanism of injury, alcohol intoxication, the type of damage, the time of primary medical care, administration of antitetanic serum, etc. Special attention should be paid to combined traumatic brain injury, symptoms of brain contusion, loss of consciousness, nausea, vomiting. During facial examination, the physician determines localization, character of soft tissue, damage, edema, scratches, bruises, wounds. Then the whole face should be palpated. The contours of the nose bones, infraorbital region, zygomatic arc, and bone and lower jaw are determined. Localized pain, pathological mobility, or bone deformation indicate some kind of a fracture. After an external examination, oral cavity should be examined. Attention is paid to occlusion, dimension, and especially mobility of the lower jaw, teeth, and buccal mucous membrane. Localization of a jaw fracture is determined depending on the displacement of the jaw fragments and the disturbance of occlusion. Neurological examination has a significant role in the diagnosis of facial bone fractures. As in most cases, they are accompanied by trauma to the peripheral branches of the triparative nerve. Uh, 2D X-ray is required. X-ray diffraction in two projections, front and collateral. X-ray picture can show the length of the fracture line, the degree of fragment displacement, bone defects and location of bone fragments, teeth location in the fracture line. The most reliable data for bone fractures can be obtained with panoramic radiograph. Lower jaw fractures. Non-gunshot fractures make up to 85% of all facial bone fractures. This is due to the anatomical characteristics, the arcuate shape of the lower jaw, and the fact that the lower jaw is more advanced. Mandibular fractures are often midline, in the area of the mental opening, in the area of the jaw angle, in the area of the ascending branch, in the area of the cervical process. Fracture symptoms. The displacement of fragments and disturbance of occlusion. When a jaw fracture is localized along the medium line, the displacement of fragments may be minimal, or there may be no displacement due to the steady traction of the geniohyoid muscles. In the case of a unilateral jaw fracture in the foramen area, a small fragment is displaced upward, somewhat forward and inward as a result of masticatory muscle contraction. A large fragment descends and shifts somewhat towards the fracture. In case of a bilateral fracture, there can be 3 fragments in the foramen area. The middle one is displaced downwards and inwards. 2 lateral fragments are displaced upwards and somewhat forward. This creates unfavorable respiratory conditions because of tongue impaction. The tongue closes the entrance to the larynx, thus dislocational asphyxia develops. In case of the mandibular angle fracture, there will be no bilateral displacement of the fragments if the fracture line is within the side of the chavin muscle attachment. If the fracture lines goes behind the muscle attachment, the fragment displacement will be the same as in the previous case in the foramen area. In case of a bilateral mandibular angle fracture, the middle fragment is shifted downwards and inwards. Side fragments are displaced up and somewhat forward. Dislocational asphyxia can be observed. Muscle injury contributes to the development of the inflammatory process, which causes the restricted lower jaw mobility. Patient's mouth is often half open, blood tinged, saliva is leaking out. When they try to close the mouth, moving fragments cause pain. Patients with the damage of the inferior alveolar nerve often demonstrate desensitized lower lip and chin, and the reduction in the pulp excitability there shown. Upper jaw fractures. Isolated non-ballistic fractures of the upper jaw are relatively rare. Due to the fastening of the upper jaw with other facial and cranial bones, concomitant fractures are more likely to occur. Classification of the upper jaw fractures. There are 3 types: lower type, middle, and upper fracture. In case of the lower upper jaw fracture, the fracture line runs horizontally above the alveolar process and heart palate, from the base of the nasal notch to the pterygoid process of the main bone. A septum nasal fracture is observed. The mucous membrane of the mouth, nose, and maxillary sinus is damaged. Patients can suffer from nasal hemorrhage. The alveolar process is mobile. In case of a medium level in this picture you can see a lower upper jaw fracture. In case of a medium level fracture, the fracture line passes transversely through the nose bone, medial orbital wall, the lower edge of the orbit at the junction of the upper jaw with the zygomatic bone and deviates backward, crossing the pterygoid process of the main bone. The upper jaw with the nose bones is separated from the zygomatic and skill bones. And in this picture you can see a medium level fracture. In case of an upper level fracture, the fracture line goes through the nose bones, medial orbital wall, the outer wall, and the outer edge of the orbit, and ends in the pterygoid process of the main bone. Along with the upper jaw, the nose bones, and the zygomatic, the skill bone comes off the skill. This is a complete craniocerebral dismemberment. And in this picture you can see an upper level fracture, upper jaw. Middle and upper jaw fractures are distinguished by a severe clinical picture. Symptoms: upper jaw mobility, lengthening or shortening of the vertical sides of the face, hemorrhage in the eye conjunctiva, eyelids and subcutaneous tissue of the intraorbital region, Racon sign, nasal hemorrhage, disturbance of occlusion. Excessive bleeding is caused by the breakage of nose mucous membrane, high sinus, and the damage of the ethmoidal labyrinth, the anterior and posterior ethmoid arteries. In case of a combined skull fracture, the patients are in an extremely serious condition: loss of contusions, spinal fluid outflow, nasal and ear hemorrhage, occipital muscle stiffness, and carrying sign are observed. Fracture treatment. Treatment implies the restoration of the damaged bone anatomical integrity and functioning. But beforehand, physicians should cope with shock, stop bleeding, replace the blood loss, etc. Anti-tetanic serum is administered. Primary quality medical care includes temporary fixation of jaw fragments with gauze and standard bandage, chin strap, gypsum bandage. Secondary care. Under local anesthesia, the fragments are repositioned in the hospital, fixed with the VPG, individual Tigerstedt or standard Vassiliev bone splint. In the case of relocation in the tooth fracture line, the tooth is removed. Jaw fragments should be fixed for 3 or 5 weeks. If the inflammatory process develops fixation, should last up to 6 weeks. A regular monitoring of the oral cavity and unhard spreading is necessary. In this picture, you can see Tigerstedt bone splint. And in this picture, show Rutschko apertures. In this, you can see Rutschko apertures on the patient too. Antibiotics and sulfonamides are used in case of open jaw fractures and the inflammatory process development. Physical factors are used to speed up reparative processes in bone tissue. In the first days, UHF and magnetic therapy are assigned. During the following 10 days, electrophoresis with 10% solution of calcium chloride. Neurotropic drugs, for example, dibazole, vitamins B1, B2, and electrophoresis with 4% solution of novocaine and 10% solution of potassium iodide are prescribed for patients with concomitant traumatic trigeminal neuritis and severe pain. Basic principles of facial bone surgical treatment. Taking into account the resistance of soft tissues to bacteria, bone surgical treatment should be carried out within 24 or 48 hours. It's necessary to remove and exclude non-viable soft and bone tissues and pathological substrate. Primary surgical treatment should be single step and radical. After radiography, anesthesia and moderate tissue excision are performed. When a wound penetrates into the oral cavity should be abundantly irrigated with antiseptics. The wound is closed with a sterile swab. Blood clots, foreign bodies, and loose bone fragments should be removed from the wound. Non-viable tissues should be incised and bleeding vessels should be ligated. of multi-system injury of the jaws and soft tissues, first of all surgical treatment of the bone tissue should be performed. Teeth roots and bone fragments are removed. Then the mouth and bone should be separated. Stitches are put on the mucous. Bone fragments attached to the soft tissue are not removed. Bone fragments of the jaw are put together and fixed. And so, in case of multi-system injury of the in case of the upper jaw fracture, operative exploration of the humerus sinus is administered through the wound. If necessary, blood clots and foraging bodies are removed. A junction with the lower nasal passage should be created. After surgical treatment of the bone wound and fragment immobilization, the wound of soft tissues is irrigated with antibiotics and catgut sutures are applied to bring its edges together. Care for patients with soft tissue and facial bone injuries. In case of jaw fractures, the patients have difficulties in chewing. Besides, self-cleaning of the oral cavity is impossible. As a result, food debris, blood clots, and wound discharge decompose very quickly. At the same time, various complications are observed. Aspirating pneumonia is possible. Medical personnel should regularly rinse the oral cavity and the vestibulum of the patient with antiseptics 5 or 6 times a day. A drinking bowl or enteral feeding tube is used to feed the patients with liquid food. And the next theme is traumatic shock prevention. Among the reasons leading to the traumatic shock development is algesic and excessive input combined with an emotional and stress component by Rozhnitsky, Zhizhin, Katkovsky. The main provision of shock prevention are formed by I.R. Petrov. To eliminate the flow of efferent impulses, to increase the circulating blood volume, to eliminate tissue metabolism disturbance, to strengthen central nervous system inhibition and to prevent infection development. According to Rozhnitsky et al., during the pre-hospital stage, treatment is unlikely to have any effective preventive effect on such trigger mechanism of traumatic shock as acute blood loss and mechanical destruction of vital organs. Therefore, only the simplest events are offered. They are aimed at the first, neutralization of reflex influences from sites of anatomical damage. The second, bleeding control. The third, blocking the emotional stress component. These principles will not only eliminate the reductions of body defenses, but also significantly increase them, which ultimately will be the basis for preventing the traumatic shock development. First aid, sedatives, analgin, promedol, morphine, etc., and at least minimal conditions of rest state lead to neutralization of the emotional component. It is equally important to immobilize fractures. Conserve heat, warm or cold, or cool the patient according to medical indications. Satisfy thirst, apply of aseptic and antiseptic dressings. All these measures can improve patient's general condition and block the emotional component, which can be enhanced by active analgesic therapy. To prevent shock at the pre-hospital stage, some authors suggest to administer pills, which individually or cumulatively help neutralize physico-emotional reaction, so that patient relieve tension and fear, and have anti-inflammatory, antipyretic, antihistamine, and desensitizing effects. Such anti-shock complex includes trixosin, andaxin, promedol, analgin, and diphenhydramine. Intervals between doses are 6 or 8 hours. The listed medicines are fully compatible and increase the therapeutic action of each other. Wait a bit, please. We start. About rehabilitation of patients with facial skeletal injuries. Rehabilitation implies organization of optimal conditions for the recovery of injured patients. The main objectives of rehabilitation are early start of rehabilitation activities, a comprehensive and individual approach to each patient and its continuity. Rehabilitation period is directly dependent on the quality of the medical care provided during the evacuation. Rehabilitation of patients with maxillofacial trauma is a regular medical check-up after reposition and fixation of bone tissue fragments in the clinic. A dispensary control card is filed in for the patient. Form number 3. If the patient is hospitalized immediately after the injury, the basic registration form is filled out before discharge, and together with the epicuritis is transferred to the responsible dental professional. In the general treatment of maxillofacial fractures, much attention should be paid to patient's rehabilitation. First of all, it concerns functional recovery of the lower jaw. Due to duration of immobilization and painful movements after removing the dental tiles, there is a need for rehabilitation, which includes mechanical therapy and improvement of the injured area nutrition. In addition, it's necessary to restore the denture by means of therapeutic dentistry. If possible, it's necessary to restore the architectonics of the damaged area of organ. In case of single mandibular fractures, prevention of the temporomandibular joint stiffness is begun in 2 weeks, and in case of double fractures, it's begun in 3 weeks. To avoid stiffness, intermandibular elastic is removed for 24 hours. Physiotherapy is also used. Magnetic therapy, microwave therapy, phototherapy, laser, etc. It does not often take much time to restore joint function after mandibular fractures. If bleeding and fever are observed during the recovery period, the above mentioned procedures are contraindicated. Passive and active mechanotherapy can be distinguished. Passive mechanotherapy implies forced dilatation of jaws and stretching of the resulting scars through using wedges, screws, and rubber bands, which are inserted between the upper and lower teeth. Such mechanotherapy is carried out for 7, 8, or 10 days, 3 or 4 times a day. Duration of each procedure is 20 or 30 minutes. Treatment of soft facial tissue injuries. Surgical treatment. Surgical treatment of facial soft tissues injuries is of considerable difficulty. If doctors do surgically manage the injuries properly and wait up to complete self-healing, sometimes they use coarse needles and large-sized stitches, which leads to serious deformations. The injury ages are not always fair. Physicians don't create cosmetic, moving, and painless scars. Not all surgeons are familiar with the stages and timing of scar formation. However, such knowledge allows them timely to intervene in the treatment of soft tissue injuries. It's very important. It's known that scars result from mechanical, thermal, chemical, and other damaging agents. Scars formation has 4 stages: the epithelialization stage, swelling follows, and compaction and softening. In general, the scar formation process lasts from 6 to 18 months. Surgical intervention are possible only within these terms. To perform recovery facial operations, one should know anatomical and topographic characteristics of the maxillofacial region, which are determined by the structural properties of the tissues, the presence of skin duplications, the direction of elastic fibers and skin tension lines, and functions of facial muscles. The success of plastic surgery depends on the skin viability and plastic properties. The tissue plasticity is its ability to form an organic bond with donor tissues after transplantation. Primary treatment should be carried out within 48 hours during anesthesia. 0.51% Novocaine is used plus 2 drops of adrenaline per 5 ml of solution. Adrenaline prolongs the Novocaine action, constricts the blood vessels, reduce capillary bleeding. Other painkillers are also administered. Plastic surgery in case of accidentally infected injuries require careful study of indications and contraindications. Indications should be wide. Contraindications are only patients' grave condition and a severe inflammation in the wound, which involves the surrounding tissues. On the face, white tissue dissection and excision is not applicable. Primary surgical treatment is carried out simultaneously and radically under strict aseptic conditions. Contaminated wounds are washed with an antiseptic solution. Only obviously non-viable tissues are excised, and the uneven edges of the wound are flattened. For the surgical treatment of facial injuries, especially the eyelids, it's recommended to use small and sharp instruments, preferably ophthalmic. For skin immobilization, extensive anatomization in one layer can be carried out. Tissue apposition before suturing should be accurate, and it should not cause facial or body asymmetry. In case of deep injuries, to avoid free space and hematoma, the subcutaneous tissue is sutured by immersion catgut sutures. It's better to use skin, hair, or nylon sutures, 3 mm or 4 mm from each other and 3 or 4 mm from the edges of the injury. The best cosmetic and functional results of soft tissue injury treatment are achieved by imposing a deep primary suture. Mobile skin on the face, a good blood supply to this area can successfully replace the worst deformities with the local tissues. Plastic surgery with gauntlet and skin grafts should be used only when local tissues are not enough died to the size of the defect. In this you can see trauma in the face. In this you can see trauma in the lower jaw. In this you can see Vasiliev apparatus. In this you can see Tigerstedt apparatus. In C you can see trauma of lower jaw. And I'd like to tell you about medical assistance during rehabilitation. Medical assistance during rehabilitation. At first aid to patients with facial trauma is provided by paramedical staff, including dentists. Such aid is considered as urgent. Paramedical staff should be familiar with the methods of temporary hemostasis, asphyxia elimination, shock prevention, and methods of transport immobilization for all types of damage to the facial skeleton. The first medical care is provided at the ambulance room of the emergency hospital in the local district or city hospitals. There should be a dentist in such a medical center, regardless of the specialization, therapist, surgeon, orthopedist. Providing qualified assistance to patients within the maxillofacial area trauma is one of the immediate responsibilities of the dentist. The orthopedic dentist is also obligated to provide specialized care. At this stage, dentists should know how to treat non-penetrating damages to the facial soft tissue that don't require primary plastics. Fractures of the teeth, alveolar process of the upper and lower jaws, and dislocation of the lower jaw. Patients with complex and combined injuries must be transported to specialized medical departments. If the patient is not transportable, it's necessary to consult with key opinion leader of the department. If necessary to provide specialized assistance and advice, it's possible to invite dentist surgeons, traumatologists, to the sense of the accident. If it's the first visit to the local, district, or city hospital, medical care should include elements of primary medical, and qualified care. When the patients are sent to a specialized department, it's necessary to specify everything that has been done to them. The circumstance of the injury, the date of the injury, the treatment, and the recommendation for the further treatment. Qualified surgical care is provided by surgeons, traumatologists, and dentists in clinic. In trauma centers, surgical departments of regional or city hospitals. This type of assistance is provided primarily to patients who need is for health reasons. These include patients with shock, bleeding, acute blood loss, asphyxia, and fatality. At this stage, final blood control is conducted. Shock and asphyxia, for example, dislocational, stenotic, obturative, valve, or aspirating, is taken under arrest. If there are no contraindications for transportation, it's necessary to anesthetize the fracture site, chop around the wound with antibiotics, administer intramuscularly a loading dose of drugs, and after immobilization of jaw bone fragments to ensure proper transportation to a specialized department. If the damage to the maxillofacial area is combined with a head injury, transportation is contraindicated. The treatment will be continued in the hospital, where the patient was hospitalized after injury. Wait a bit, please. Thank you for your waiting. We are start. I'd like to tell you about occlusion, types of occlusion. Occlusion means simply the contact between teeth. More technically, it's the relationship between the maxillary upper and mandibular lower teeth when they approach each other as occurs during chewing or at rest. The number of teeth in a permanent occlusion is 28. People whose 8 molars have erupted normally have got 32 teeth. There are 14 teeth in each jaw. The following groups of teeth can be distinguished: incisor, first and second; canines, third; premolars, fourth and fifth; and molars, sixth and seventh. The shape of the upper row of teeth is semi-ellipse, while the lower teeth form is a parabola. You can see it in the picture. In physiological occlusion, the habitual position of the lower jaw coincides with its central position, but in abnormal occlusion it does not. In the case of an anomaly, the occlusion type is determined in the position of the lower jaw, which is customary for a particular person. Thus, we should emphasize that the first sign of occlusion is teeth joining or its absence, disocclusion. Signs of physiologic occlusion. Upper lateral teeth overlap the lower ones to the depth of the longitudinal fissure. In the frontal area, the upper incisor overlaps the lower incisor by no more than 1/3, and there is a contact between them. Each tooth has 2 antagonists, except for the last upper teeth and the lower central incisors, which have only 1 antagonist tooth. The midline runs between the central incisors. Teeth join each other on the proximal surface, sideways. The height of the crowns decreases from the central incisors to the molars. Canines are the exception. They are always larger in size. The upper teeth are tiled vestibularly towards the lips cheeks, and the lower teeth grow vertically. First molars fit together in the following way. The mesolabial tuberosity on the first upper molar is located in the intertubercular fissure of the first molar of the lower jaw. The upper lateral teeth overlap the lower ones to the depth of the longitudinal fissure. In the frontal area, the upper incisor overlap the lower incisors by no more than 1/3, and there is a contact between them. The upper teeth are tilted vestibularly towards the lips cheeks, and the lower teeth grow vertically. Uh, in this picture, picture right, you can see the midline runs between the central incisors. And in the left picture, you can see the middle incisor line doesn't match. In this picture, you can see first molar fit together in the following way. The mesial labial tuberosity of the first upper molar is located in the intertubercular tissue of the first molar of the lower jaw. Orthognathic occlusion is an ideal smile. If you look at the photo of an orthognathic occlusion, you can see beautiful and even teeth. The orthognathic jaw's ratio is a correct physiological position of the jaws, and even the tension at the normal ratio of the upper and the lower teeth. Anomalies of the detention occlusion according to the classification of the Department of Orthodontics, Moscow State University of Medicine and Dentistry by 1990s. At first, sagittal imbalance, lateral segment or anterior segment. In lateral segment may be distal anomalies or mesial anomalies. In anterior segment may be sagittal incisal disocclusion, reverse incisal occlusion, reverse incisal disocclusion. In this picture you can see sagittal imbalance. In the lateral segment, distal lateral occlusion. In this, you can see lateral anomalies in lateral segment, mesial lateral occlusion. In this, you can see sagittal imbalance in anterior segment, sagittal incisal disocclusion. In this, you can see a reverse incisal occlusion in anterior segment. The second, vertical imbalance. It may be in lateral segment and in the anterior segment. In lateral segment may be disocclusion. In anterior segment may be vertical incisal disocclusion, deep incisal occlusion, deep incisal disocclusion, and direct incisal occlusion. In this picture, you can see vertical imbalance anterior segment, vertical incisal disocclusion. In this picture, you can see deep incisal occlusion in anterior segment. In anterior segment, deep incisal disocclusion. Occlusion, disocclusion. Vertical imbalance, lateral segment. In this you can see disocclusion, lateral disocclusion. The third, transversal or horizontal imbalance. Lateral, it may be in lateral segment or in the anterior segment. In lateral segment may be vestibular occlusion, palatal occlusion, and lingual occlusion. In anterior segment, you can see transversal incisal occlusion, transversal incisal disocclusion. In this slide, you can see transversal imbalance and in anterior segment, transversal occlusion and disocclusion. Disocclusion, right, occlusion in the left picture. In this, you can see transversal imbalance in the lateral segment, cross-bite occlusion. You can see in the oral cavity from your patient physiological tremors and diastemas. Diastema in the front and tremor in the lateral segment, you can see in this picture. Okushko defines bad habits. Frequently repeated contractions of the perioral muscles, tongue, movements of the lower jaw associated with sucking and biting fingers, lips, cheeks, and some object. Habits associated with dysfunction of chewing, swallowing, breathing, and speech. Habits associated with postural difficulties, erectance, wrong position of the lower jaw, and the tongue. In this picture, you can see bad habits by Okushko. Every second habit, lips, cheeks, fingers, or object results in malocclusion. You can see it in this picture. It's very important. Researchers have identified a correlation between surgical occlusion anomalies and postural disorders by Gioeva and Birukova. Conclusions: in children with surgical occlusion anomalies, postural abnormalities are more common than the national average. Postural disorders in the sagittal plane dominate in patients with distal occlusion. Various types of scoliosis prevail in children with mesial occlusion. Postural disorders affect the size, position, and direction of the jaw growth, as well as dental inclination, tooth, alveolar height, and sagittal overjet. The direction of the jaw growth in children with mesial occlusion depends on the posture. Also, improper body position while sitting, supporting the head with palms, or resting the chin on a solid object lead to dental-alveolar anomalies by Horoshilkina. The habits of sleeping in one position also affects the development of dental anomalies. In this